Okay, well, it's 1600 here. Let's think about getting started. Thank you, everyone, for joining us. And it is my great pleasure to introduce my friend and colleague, Jonathan Clark, to you today. John and I worked together at Baylor College of Medicine. And before that, we were both at NASA. And before that, he did some amazing things. We posted his bio, his full bio, in your Google Drive, so you can read more about him if you want. He has been a flight surgeon for quite some time and has a lot of expertise to share. And I hope that you're all ready to receive this torch that he has to pass. Take it away, John.
Okay, so I'm going to start the presentation. Hopefully this shows up. So are you all seeing my first page?
Yep, looks good.
Okay, so I'm going to have to scroll through this pretty fast because I've got a lot of material and 2 hours to talk about it. So this was the Ginger wanted to have a talk on medical mission needs, which is not what I had done before. So I had to kind of throw stuff together, and hopefully this will suffice for your needs. So I have to put a disclaimer in there because, you know, if you guys send my thing out and somebody says, oh, you know, this guy was at NASA. So nothing I say, it represents any agencies I'm affiliated with. And like I say, and I had to update this. Last time it was 50 years, now it's 60 years. So speaking for myself for over 60 years. I always like to start with talking about human spaceflight with the statistics. And to be honest with you, we don't have a huge amount of time in space as humans. It's, you know, obviously started in 61. So we have, you know, just shy of 60 years worth of time in space. And of that time, you know, for people flying in orbit, which is less than the people who've flown in space, it's only 560. And what's really sad is, you know, how few women have flown in space. It's probably in the, you know, 10% range. So most of the long duration records are held by the Russians because they started flying space stations in lieu of going to the moon. And so you'll see all the long duration single mission records and cumulative records in the hands of the Russians. The bottom is probably the most important, which is how many people have flown cumulatively a long enough mission that would represent a mission for an exploration class mission. And those are, you know, probably the shortest mission you could go to Mars, and I'll talk a little bit about that, would be maybe 600 days. And that would include, you know, about a month-long stay. And the shortest mission you could fly for an appreciable period of time would be probably in the order of 850, 900 days. So what we do, we have a couple of people that have flown over 800 days total, but it's only three people. And we are not building enough time on long duration to really understand the effects of spaceflight. And all of that has been people that have flown in low Earth orbit space stations. So I like to break down the threats to human spaceflight into two general categories. Ones are the extrinsic threats that are physical threats. And those are things that NASA calls hazards. And the other one is intrinsic threats, which are basically what we bring to the table as humans, which are spontaneous medical events. So what you see there is that we have to contend with not just the fact that we carry our own risks of medical events, but the extrinsic threats, which include the space environment like radiation and microgravity, and the vehicle environment, which can be mostly reflected by small spaces, loud noises, toxic contaminants, and then the things that we make our crew do, which could be high workload events or shifting circadian rhythms. All of those conspire to impede the human's performance in this kind of environment. And it really is amazing that we've been able to do it so successfully. So that's Mir Space Station. That was one of the, you know, obviously the Russians flew Soyuz missions before that, but the Mir Space Station was really one of the early long duration, where most of the long duration early records were set. The early Salyut space stations didn't stay up long enough to set long records. I put this down there, and the bottom is the link to it, but this is all the bad stuff that's happened in space. And it's a lot of stuff. And each one of those, if you click on the link, it's now electronic, so you can open it up and it's updated. But all the red stuff is fatalities. The oranges are serious injury or life-threatening, potentially life-threatening events. And then the yellows are close calls. And then the whites are just things that failed. But what you see there is a lot of system failures and a lot of human factors incidents. And I'll go through a few of those just to highlight the issues that we have to concern, particularly as it relates to space pharmacology, which is affecting higher cognitive function. There's another shot of Mir Space Station where a lot of the early events happen. Now, I won't go through in detail a lot of the specifics in the text slides. That's for you all to peruse at your leisure. And then if you have specific questions about it, I can give you more details. And I'm sorry, some of these things will have abbreviations, as most things in the space program do. So if you're unfamiliar with those, just let me know, or I can tell you. But we've had what I would call significant, besides the fact that we've lost 2 Soyuz crew and 2 shuttle crews in the pursuit of space exploration, we've had some really close calls. And by close calls, I mean the fact that the space stations were abandoned because of events that happened that had medical implications. Most of those early on were in the Russian program because they were flying long duration missions and we were just doing lunar exploration. But we had 3 of those that happened. One was a severe combustion event in a Salyut space station. The crew elected to come home a week early because of symptoms. There was another Russian mission where a male crew member developed a serious urinary tract infection. And then the third event, which resulted in an early mission termination. And both of those latter ones interrupted the mission halfway through. So they were, into missions over 6 months originally planned that were truncated. And then there was 3 other close call mission. The missions weren't aborted, but they were in the process of being aborted when the medical event was eventually resolved. And those included a dental abscess, a toxic event, which was really close call, and then a kidney stone. Now, we'll talk a little bit about extrinsic factors such as, vehicle events related to environments. And we've had what we call euphemistically combustion events, which were another term for a fire. A fire is a serious event in a closed loop system. And in fact, the 3 main events that are considered class 1 or serious, immediate response required are fire, a loss of pressurization, and toxic events. And obviously fire and toxic events can be related, but don't necessarily have to be. We've had a ton of things that have happened to crew in the highest risk part of the missions, which are spacewalks, also called EVAs or extravehicular activity. And I just list those EVAs that were terminated early, injuries that occurred on the moon. We've had, in the course of the Mir and space station, multiple crew that have lost tools. And this is a representative of the severe cognitive load in crews doing EVAs and the fact that they fail to tether their tools to themselves. And in one case, one crew member actually failed to tether themselves. That is a serious, serious issue. The medical events that have happened in space, some of which are on that previous list I showed you, which has a website link, include pretty much all of the various organ systems. And the performance events, which are really critical, obviously represent coordination, crew coordination, and human factors related events, have all resulted in close calls, and some of those are on that list as well. The Mir the collision of Progress cargo module in '97 with the Mir space station was a human factors event. Now, you will probably get some of this from other lectures, but each organ system in the body is used to adapting. All species, and particularly humans, have to adapt to their environment. And to do that, their bodies change characteristics in response to significant changes in the environment, such as altitude, temperature, and whatnot. But one of the things that we have always had on Earth, no matter where we've been, has been gravity. And until we started flying an aircraft where you could push over and reduce the field of gravity for maybe 20 seconds or so, we have never been out of the environment of gravity. And so the body is now, we are learning a huge amount in space on the effects of the absence of gravity. And what you see there is all the organ systems have adaptive time constants, which are different. And the nervous system in particular is a very rapidly adaptive time constant. The cardiovascular system and the shifting of fluids and kidneys' response to that are very, on the order of days and up to weeks. And then you see all these other effects. The solid blue line, which shows the loss of bone density, we have not seen a plateau in the months that we've flown. In other words, there's always this 1% to 2% loss. So that is a serious issue. And the other one that's a constant that continues over time is the effect of radiation, the dotted black line. So these are things that we are really concerned with because we haven't seen the body's adaptiveness to that. Now, as we adapt to the novel environment, we also readapt once we return to a gravity field. And the time constants for that recovery are different than the original adaptive time constant. So the readaptive time constant is different. You can imagine the effects that this is going to have on pharmaceutical effects. The fact that you're also changing the physiology and response. And this is just a list. I won't go through this in any detail other than if you have other specific questions about it, you can send me some queries on it. I'm a neurologist, so most of my interest has been in the nervous system, and particularly the vestibular system, but I also dabble in the neurobehavioral part of it. But the bottom line is we've had a lot of different effects of the space environment. And those relate to those extrinsic factors, the loss of gravity, perhaps the radiation effects, a variety of other things. Even sleep is perturbed in space. Now, where we're going here is, this is now, we're going to talk about deep space exploration missions. And the concept of exploration mission has not been absolutely defined, but I would say that it's going to be beyond low Earth orbit, outside of the protective Van Allen belts, and for mission durations of in excess of a year. And what you can see there is these are the planned missions that are going to be ongoing in the near future, including perhaps a return to the lunar surface to start short sorties and then build that basic experience. People often say, well, we should go right back to Mars. And my feeling is, if anybody who's ever done expeditions knows, you always start with a base camp. You have Everest Base Camp. You always have some place where you can support the tip of the spear, the farthest point away. And the moon is a perfect base camp. It takes more energy for the propulsion system to get there, but once you're there, you can start using the partial gravity surface to understand the effects of gravity or loss of gravity, and also you can mine materials, particularly water ice, which is in the lunar polar regions. So anyway, this is a good slide to show you the duration effects of the different missions that are planned. And again, if you have further questions on it, let me know. I was involved with a project that was going to do a Mars flyby mission, and that's now on hold, probably permanently, because it required some support from NASA. But Mars is really interesting because it has seasons. You can see the change in the polar ice caps on Mars. It is a smaller planet, and it's got about a third of the G of the Earth, but it also has weather. It's got an atmosphere of about 1%, mostly carbon dioxide and argon, and it's close enough that we can get to with conventional chemical propulsion systems. I love that this just shows some of the newsprint articles on Mars and why there's been an interest there. And I love this slide. You know, we're looking for intelligent life, and you see a little happy face, and you see hearts on the lunar surface, and you see there's a face right here in the center picture, and all kinds of pyramidal looking structures. So it's a fascinating geologic place. Now, to get there, these are just two representative missions where you could go for not a flyby mission, which is the one I was involved with, but a short stay or a long stay. And these are taken, there's periods of orbital mechanics that allow us to do the shortest possible transits to the moon, or to Mars. And Mars, so the moon is about 250,000 miles away. And Mars, although it's an extent, you know, depends on where we are in our rotation cycle, it's about 35 million miles away. But it changes its distance based on orbital mechanics. And using those orbital mechanics, we can do the shortest possible transit for the time we want to stay on the Martian surface. And so here's an optimal mission on the left that shows a mission of about 650 days, where you could stay about a month on the Martian surface. So you're spending most of your time in transit, about 600 days in transit, and about, you know, just over a month on the surface. And that's a pretty doable mission, but you can only do that on increments of every so many years, which is, it may result in cycles that are only 7 to 11 years that you can do that. So that means you have to plan and be ready to launch and have that window to launch and get there and then stay for that period of time and return. The long stay missions are really where you have an optimal time on the Martian surface and only a 6-month transit each way, but those occur infrequently as well. That's called the long stay conjunction class. The short stay are called opposition class, and it has to do with where the departure and arrivals to the Earth come. But again, those are only in very short windows to provide. Otherwise, you would spend a longer time in the transit in deep space, traveling that 35 million miles. So the things that drive humans being able to survive in a space station is because they're in a pressurized volume is the vehicle size. And this is a very wordy text slide, but it basically shows how much we would need for crew, which is dependent on the duration and also the crew size. Mostly it's the crew size. And what you see there is that we have the basis of where we are in ISS. We have 1,000 cubic meters of total pressurized volume, and about a third of that is habitable volume. Why is that? Because most of the equipment inside takes up a lot of space. If you think about the rack panels on all four surfaces. But 65 cubic meters per person is huge. That's a really good number. So ISS is not necessarily a good test bed for the small confinements we might face for Martian missions to Mars or deep space. And what else? And if you look at what we have on nuclear submarines, these are missions that are at most maybe a little bit, maybe 7-month missions. But those are they're certainly well within that optimal window, either for a performance limit or optimal. Now you can confine people to small space as low as 5 meters cubed, but boy, that's tolerable, but it's really probably insufficient for optimal performance. We have an undersea habitat, and you can see that that's in that smaller, very tolerable level, but that's only for missions of 2 weeks or so. And that's probably about what the space shuttle had. And then this just shows these curves are set for 300, 400-day missions. But what you remember, what we're talking about, the shortest mission we could do to Mars is going to be 650, 700 days. So that's way out in this unknown space. And really, we don't know how that's going to play out. So we'll talk a little bit about risk and hazards. And this is NASA's definition of how they approach it. The hazards are the physical extrinsic factors, and there are 5 of those. We'll talk a little bit about those. And the risks are the consequence of those hazards on the human as it interfaces with the human-machine mission system. And here's the interesting thing that most of you may not appreciate is the risk for vehicle failures for a variety of reasons is always higher than the human system risk. And so a key component is that we have to balance the vehicle system risk with the human risk. And one of the ways that you buy down human risk is by rigorous selection. Now, this came out, this is written by Jim Bajan last year, and he tabulated, this is part of the NASA Aerospace Advisory Safety Panel, and what they found was the risk in the space shuttle was far greater than it was originally designed. They thought the risk was probably 1 in 250 loss of vehicle and crew, and early in the program, it was 10%. The shuttle Challenger on the 25th mission broke up on ascent, and that was these figures, 1 in 10, and as it gradually improved at the end of the shuttle program, it was just shy of 1 in 100. But you know what that is? That's a World War II bomber crew, daylight bomber crew in the European Theater of Operations, where they lost over 250,000 crew members. And they would lose a third of the squadron on some of the earlier missions. So when people talk about space risk in a winged vehicle in low Earth orbit, we're talking about loss rates approaching a bomber crew in World War II. Now, to give you the perspective, what's the loss rate in commercial airlines? It's about 1 in 10 million. So that's 10 to the minus 7th. And this, at the very best, would be 10 to the minus 2. So it shows you what loss rates are. I fly general aviation aircraft, and our loss rate is about 1 in 100,000. So that's 1 in 10 to the minus 5. The vehicle loss rates for projections, even in the future, are always around they're in the 1 in a 500 or so. So that's, you know, at best it's 1 to 10 to the minus 3, and at best 1 in 10 to the minus 2. But vehicle loss rates are a very significant issue. So we have to contend with how we balance risk for the system and the medical part of it with how much we provide to support the crew. And what you see there is, as you increase the mass and volume of the medical system, you decrease the medical risk, but you're paying a penalty because now you're not paying attention to other things. You can only take so much. Here are the hazards as they break out, and this is a really cool slide. So obviously we have radiation, and deep space radiation we have very little experience with the human in. We have the altered gravity fields because of the long transit, where we may or may not have artificial gravity or some other countermeasure. Enclosed spaces, isolation, confinement, which are also related, and then distance from Earth is going to significantly compound our issues with respect to replenishment and also communications. And this is a view taken from one of the Mars rovers, and this little white dot is Earth. So we have experience where the size of the Earth from our perspective on the moon is, if you hold your hand out and look at your thumb, that's how big your thumbnail is, how big the moon is. Imagine when it's barely a pencil dot, and it might not even appear blue unless you have magnification. So the next part of it is, and this is, you know, obviously NASA's got a huge program, but so does the European Space Agency and other ones, but they all follow along and do things in a similar fashion. But to deal with this, we have research that's broken down on approaching the risks. The risks are based on the individual human element hazards, the response to those hazards. So we have human factors and behavioral performance, which addresses the workload, cognitive risk, and behavior and performance. Exploration medical capability is where most of the pharmaceutical interventions involved, and those are made up of, that's the exploration medical capabilities, and mostly made up of flight surgeons. We have the health and human countermeasures, and we have space radiation, and this bottom one, research operations and integration, just takes the research and tries to make it operational. So NASA uses this human risk roadmap, and you may get exposure to this if you watch the talk by Ben Easter, who's a great guy. We take what we know, which is evidence, we look at the risk profile, we identify gaps, we look at those gaps and try to assign tasks for research, and the research product is the deliverable. Human factors and behavioral performance has 10 risks. Exploration medical only has 5, and that's actually the one I work with mostly. Human health and countermeasures has 17, and radiation has 3. So that's 35 risks. Now, you could say there's a lot more out there, but believe it or not, these folks are extremely tied up in just trying to understand these. This is broken down by the hazards and the various risk gaps that are identified. And you can see the ones in red are the ones related specifically to pharmaceuticals that I've outlined there. But anyway, this is all available for your perusal. Now, that's not to say that these are not interacted with in other areas. For example, radiation has a huge effect on potential shelf life, yet it's medication is not in the radiation risk category. It's in, distance from Earth and altered gravity. And that altered gravity reflects the concern about the altered physiologic effects on organ systems that might relate to how a drug is processed. And that's something that you'll get in some of your later lectures. So our challenges for deep space can be summarized as to the following. We do not have a lot of experience outside of low Earth orbit. The lunar missions, which were relatively short stay, in deep space, maybe up to a week at length. And only 12 people have been in the lunar, or 24 people have been in the lunar environment. Outside of the Earth's magnetic fields, the Van Allen belts, we get far less protection by an order of magnitude. And you'll have some great talks on radiation, so I'm not going to cover that here, although I do in other talks. Comm delays are a big, big issue. And that's, two-way comm delays at the best of times when the Earth and Mars are not very far apart. It's still an 8-minute delay round trip. That precludes real-time support. You can do store and forward, even though 22, believe it or not, these are being simulated now in some scenarios, and it makes it far more problematic because we've never had comm delays this long. We've had 3 or 4 second delays to the moon. Remember, that's only 250,000 miles away. A long mission, we're talking about missions that are 650 to 1,000 days or longer. How do you keep crew proficient with all the things, particularly, as they relate to contingency medical events? Our big problem is going to be we have to send stuff ahead of time and pre-position it, and so that's obviously going to have an effect on shelf life. And then we have no ability to return immediately like we do from the space station or even from the moon. In Apollo 13, they did a lunar flyby and then returned to Earth, and that took 3 days or so. And that's not a bad time delay. I will point out too, there are periods of time in the comm delay arena where Mars and the Earth are separated and the sun is in the way. And during that 2-week period, there is no comm support. So this is a good summary slide of some of the challenges we face. That's the Earth, a pencil dot seen from Mars. That's an actual picture. Now, you might say, well, what are we ready to go to Mars? Well, I mean, thanks to a lot of the efforts in the commercial space sector, primarily SpaceX and Blue Origin, they're already actively pursuing architecture studies, and Falcon Heavy would be one of the key vehicles. And this one was launched just a couple of years ago, and it does propulsive landing. Now, propulsive landing saves money on Earth, but the real reason you need propulsive landing is to land on the moon with large structures. The lunar rovers that came down used they used airbags, and they bounced around a lot, and then they've been just now starting to use propulsive landing for the Curiosity rover, which was larger. That was the size of instead of a size of like a little all-terrain vehicle, they were the size of a truck. So we're going to have to do propulsive landings, and so the technologies used by both SpaceX and Blue Origin are very instrumental in landing on the Martian surface with structures like a habitat. And then, of course, he took, to show his payload, he sent his old car up into space. And this is an actual picture. I mean, everybody I've seen that sees this says, oh, there's no way. How did you get the shot? And he had a long boom with a camera on the end of it, because it looks like it's surreal. And obviously, down in South Texas, this is the Boca Chica launch facility. They're up to serial number 4 of their test vehicle. They've blown quite a few of these up, which is part of space exploration, test, and development. And that's an actual picture. That's an actual person in a SpaceX spacesuit, which I had the opportunity to be involved in the first human vacuum exposure next to a test vehicle. Pretty cool. This stuff is for real. This is a talk that Elon Musk gave, I think, in 2016. And he has a very robust architecture that shows his plan for colonization on a Martian surface. Now, this sucks here. It's 1% of the atmosphere of Earth. So, and at 1%, your blood will boil. And I actually could show you some cool videos of that. In the interest of time, we won't be able to. So, what are some of those challenges we faced in the medical arena? These are highly screened and selected astronauts who were active astronauts at the time. They developed this list of events on the Earth's surface. If they had occurred in space, even in low Earth orbit, we would have been in some cases, really hard pressed to bring them home alive. And particularly the itises, the inflammatory infections of the intestinal tract, including appendicitis, diverticulitis, gallbladders, pancreatitis. Those were ICU critical care situations. Ulcers and kidney stones. We've had 10 astronauts that have had 14 kidney stones, and they still are flying, but there's a lot of issues with kidney stones because in the absence of gravity, our bones start to shed calcium, and that calcium goes into the bloodstream and then is filtered by the urine. So we're at risk in the microgravity environment of kidney stones, and one has actually happened in a Russian crew member in space. Anyway, we use this as the foundation for the exploration condition list, which is all the conditions that we would consider we could treat in space. And I'll get to that in the next talk. Here's the risk factor we face. This is based on looking at a lot of data from Antarctica, the previous Russian missions, military experience primarily in submarines, is what's the chance of somebody developing a medical condition of significance that would require intervention in a year's period of time. And it's essentially, per crew member, it's about 6% or, 0.06 chance in a crew member per year. Now, obviously, the more crew members you have, that risk goes up. And then for those that would require an ICU stay, that's about a third of that risk, or about 2%. So those are people that would require intensive support. So this risk, what you see is for a mission of 3 years in a 6-person crew, that's a substantial chance of a medical event happening. Now, this is an interesting one too. This is based on a projection from ISS experience. Where does that risk lie? Most of the risk is medical risk. Some of the risk, probably the least amount of risk, is injury and trauma, although that will change in gravity fields like the Martian surface, where we can have gravity effects and injury and trauma. We saw it on the lunar surface. And then environmental effects, that's a loss of vehicle systems. I think that risk is actually a little bit higher, but for sake of our purposes, the main risk category we face, considering illness, injury, and environmental, the vast majority of it is in the medical arena. And this shows you that maybe 1 in 100 would be a loss of crew, in other words, a fatality. So this is a good source for us to support why pharmaceutical intervention is important. Now I'll just share with you a few events that have happened. This was Jerry Leninger on the NASA Mir mission he flew in the mid-90s, resulted in a fairly substantial toxic event. We talked about this earlier. Combustion events on Mir, shuttle, and ISS, toxic environment, which are not necessarily from combustion events, although this one here was. This was a carbon monoxide level on a combustion event on the Mir space station and Andy Thomas's mission. And they were not treated with oxygen, which is the mainstay of pharmaceutical therapy for carbon monoxide poisoning. I'd like to point out too that we've also seen some substantial water contamination, including formaldehyde and cadmium, which is a heavy metal. That's a serious concern, and it is why we have to test our life support systems for so long. This is a picture of Valery Polyakov on the Mir space station, and he would spend 3 or 4 hours a day exercising, and the rest of the time, he spent 14 months on this, longest record anybody's ever done. The people that have flown one-year missions are all mostly in the Russian hands, even though Scott Kelly flew. His was only 340 days, and so they call it a one-year mission, but it's not really, you know. But Valery Polyakov spent the vast majority of his time looking at Earth. Obviously, it's a great thing to look at, but when you're on the moon, it's the size of a thumbnail, and on Mars, it's the size of a pencil dot. These are the things that have happened in flight from a behavioral health standpoint. And let me tell you, I do a talk on it, and if you're interested, I can send you the video links, because that's the one I do for Baylor, but it actually has some video of some of these. But these are serious, serious medical behavior. These are serious behavioral events. You know, we've had crew members that were contemplating suicide. We've had grief withdrawals. We've had homicidal thoughts. And we've had interpersonal reactions, including fights in space, which got to be pretty cool because, you know, you don't have gravity. And also essentially mutinies where the crew shut off comm with mission control. I spent a lot of time looking at performance effects, and these are some of the things astronauts describe their experience in space as a cognitive slowing, or space stupids is the common term. This was a French astronaut who described mental viscosity very eloquently. You know, it's like his brain is thinking in oatmeal. They've resulted in errors. We've had collisions. We've had robotic arm collisions with satellites, missed checklist items. Oh boy, this was Skylab 4. They failed to perform the checklist right, and they had an exposure to a toxic environment because they missed checklist items. And we've had, like I said, over 43 tools lost on spacewalks. This is a great picture to show you some of the cognitive effects. The crew had serviced their spacesuit, and they put their boots on backwards. Now, something as minor as a boot fit problem can be consequential. And you know, if any of you are skiers, which you might have had, where your boot fits don't, you know, if you're renting a boot or something and it doesn't fit right, how excruciating that can be. Imagine when you're out in space and your boots are on backwards. I'll get now into the thing that I spend a lot of time with in my current capacity, is on the NASA the neurologic effects and which is called Spaceflight Neurologic Syndrome. Here you see Peggy Whitson. Look at how puffy her face is. And that was puffy the whole time she was up in space. Now, it's great for getting rid of wrinkles, but it has some adverse consequences. Here you see her ground photo. This was, she's our long duration record holder in the U.S. Astronaut Corps. It's over 600 days. Look at that puffy face. What does that puffy face do? It has effects that we've now been tracking since 2005. About anywhere from half of the crew members have this problem. The worst thing we'll talk about is the swelling of the optic nerve head, which is representative of increased intracranial pressure. You can see there that this is the optic nerve sheath, and it shows this balloon structure from this increased pressure. What that increased pressure does is it puts pressure on the back of the globe of the eye and causes a change in refraction. So crew members can't see things up close. And there was actually one mission where the crew member couldn't read his checklist for his reentry prep. Here's a picture of choroidal folds, which show the buckling in the back of the eye from those displaced ocular globe. And like I said, we've had about a third of our crew members. This was up to Expedition 57. I think we're up to 65 now, but it's about a third of our crew members who have these various findings on a physical exam. And the latest concern, which is this just came out the end of last year, was essentially the cerebral venous drainage system is showing stasis, which is slow blood flow. Ordinarily, when we're sitting upright, the blood flows out of the brain, and we spend 2/3 of our time sitting upright in some capacity and only 1/3 of our time sleeping. The real significant consequence of this is thrombosis, which is a blood clot. And this was actually a demonstrated blood clot in this article. And we have now had the first case of use of a oral anticoagulant in space in the treatment of this. That has also just been published. Here's a photo of the brain before and after spaceflight. And what you see is the brain displaces upwards and compresses structures on the upper part of the brain. And there's a large, the superior sagittal sinus is a large venous structure there. So this is post-flight when you're back on Earth. So we're really trying to get a handle of what's going on in space. Now, in the last few minutes we have, this is a slide that shows use of medication. And now I use the Space Shuttle program because that was heavily documented and is now finished. But what you see is there's 4 main kinds of drugs that we use. And Ginger will probably talk about this further, but early on in the, immediately after getting into orbit, we see space motion sickness, which is identified as SMS. And that affects about 2/3 of crew, and about 10 to 15% of the crew members are physically incapacitated and are required parenteral injections to manage that. So essentially, if you look at these, the majority of these drugs are psychoactive drugs. Analgesics, anticholinergics for motion sickness, and sedative hypnotics for sleep. So what you see there is the potential for cognitive effects that are going to be compounded by the fluid shifts and also by the fluid shifts and the space stupids. And you'll get more of this in some of the pharmacology talks later. But I wanted to share with you, this is all information that was obtained. It's not going to be published because NASA has a thing about not wanting to publish any medical crew issues that can be traced back to the crew. But these are cases that I'm very familiar with because they happened on missions I was supporting or was the head of medical operations when this occurred. This was an astronaut that after his mission, when he filled out his drug use checklist, he said that he took 6 promethazine or anti-motion sickness pills prior to his spacewalk. And that is a whopping dose of promethazine. Now, he says himself that he didn't have any cognitive effects, which is kind of makes you wonder if there are some major changes in how the pharmacokinetics and pharmacodynamics work. This is an astronaut also who was involved in a spacewalk, and holy cow, this came out after the mission. He lost on 2 separate spacewalks. This is well into the mission, lost 2 tools. Now these tools you might not think are expensive, but they're very specifically designed, and they're millions and millions of dollars. They cost millions of dollars. And this crew member, as it turns out, was taking a long-acting sedative hypnotic, which has an active metabolite. And this is one that Lakhutka and I worked on to analyze. But he's on Dalmane. And there were other better drugs available, but he liked Dalmane. And unfortunately, the crew surgeon could not stand up and say, hey, we really don't think you should be taking this. But he'd been taking it before flight and in flight, and had 2 clear performance effects. Now, one of the things you say is, well, you know, he wasn't sleepy, but what he had was disinhibition. And so he was going through his checklist and he was skipping items. Now, that could be partly due to the space stupids, but there's no question he had active metabolite in his system for the period of time during those spacewalks. And I actually wish we could say this was a performance-related effect that was clearly related to a therapeutic misadventure. We had another astronaut. Crews prior to launch get real antsy and they're not sleeping well. And so he took too many short-acting sedative hypnotics before the launch. And during the first few days of the mission, he was essentially incoherent and was basically just slept on the, on the shuttle until he woke up a couple days later. These are really serious events because they affect crew performance. Here's the other ones that we've seen. We had an acute behavioral response, which also you could say was a performance effect with hallucinations. And after this, we started doing pre-testing of medications. In other words, crew will come in, they will get a pre-tested for all the drugs that they could be exposed to, particularly sedative hypnotics. And then they're actually tested and woken up. They come into the JSC sleep crew quarters and they sleep, and then they wake them up several hours later to make sure that they don't have a hangover effect. I can tell you unequivocally, we have seen anticholinergic urinary retention in space. And I think this number is actually up in the about 10 cases, but these are 4 I actually worked on. And one crew member had to be catheterized for the entire mission and had a urinary tract post-flight. And then we had another crew member. All crew members who do spacewalks take in decongestants, with a nasal spray. And, you can have rebound effects if you use it too frequently. But this person had a cardiac dysrhythmia during the spacewalk. Do I know it absolutely for certain it was the sympathetomimetic? I don't know, but we suspect it was. So anyway, these are some issues that I came up with for you all specifically. One is this program of pre-testing all psychoactive medications that the crew may need is really an important lesson that we've learned, and that we also put them in the crew quarters sleep lab, wake them up halfway through it so we can see if they have this severe hangover effect. Probably one of the biggest issues is pharmaceutical shelf life, and I don't know how to get a grip on that. If there's ways we can shield it, because we know that some chemical bonds, I think disulfide bonds, are particularly vulnerable to radiation. Here's one I came up with recently, because right now we are doing extensive urine recycling, including we recycle all the condensate which is absorbed from the humidity collection system. And that would be, easily recyclable, but we're recycling urine now, including the Russian urine. And we do about 93% recycling. We're going to be doing different kinds of recycling systems for these extremely long missions. And right now we bring up water on the Progress resupply and the SpaceX Cargo Dragon module. But when we're in deep space, we are not going to have necessarily the ability to replenish water until we get to, a surface like Mars where we can recycle water, or the lunar surface, which has water ice. One of the things I'm really big on is we got to learn how to turn surgical disease into medical disease. And that's something that they do on submarines, where they've managed acute appendicitis with, antibiotics. Should we be looking at 3D printing of medication as both a way to prevent or prolong shelf life or prevent degradation? That would certainly be a cool thing. And I think we're going to need to look at that. And then the other thing is to start studying the effects of radiation in deep space on medication. So that's your task. I'll talk a little bit about where we're going in the line of technology development. One of the things that we had actively pursued in the Inspiration Mars program was a astronomics program to heavily utilize the new expanding field in omics research. And these are just, obviously omics encompasses DNA and RNA and protein transcription, and also our interaction with our microbiome. But this is now being used in extensively in cancer chemotherapy. You test the omics compatibility with the pharmaceutical agent that you're going to use, and see if this, why waste time seeing if it's something, especially a toxic agent like a cancer chemotherapy agent, and test it beforehand and know that it's going to be effective, as opposed to a population-based study and where we're really doing a trial and error. We're going to have to go to this individualized precision medicine approach for everything. And this is some of the work that's being done particularly in the important area of cancer and also for astronaut radiation risk. And these are some of the references that you can look up if you're interested. We also, and this is an article by Mike Schmidt, who's a good friend of mine, on personalized medicine for spaceflight. So this holds tremendous potential. This is data from the 520-day study that showed the sleep cycles for crew members, and in particular to point out the well-adapted subjects and the one that was basically running on a free clock. And of those 6 crew members, which were multicultural, at least 2 of them had significant performance effects because they did not sleep well. And so the understanding of how we can optimize sleep, perhaps with an omics solutions, is really crucial. We can't afford to send somebody on a 500 or 600 day, and 520 days is can you imagine crew members? This was a terrestrial study, but we haven't done a 600-day study, which 650 day is probably the minimum we can get by with, and even a 1,000-day study. So we need to be doing analog testing and seeing if there's ways we can exploit the omics technologies. So this is my kind of summary. We're going to need to have this personalized precision medicine in all aspects, this particularly in the space pharmacology arena. We're going to need to focus on the very first thing is to make sure we don't degrade performance, so crew members don't make things worse by a human factors error. And crew health is obviously a long-term consideration, but also for short-term, but particularly as it relates to performance. We need to get into and heavily exploit non-invasive healthcare monitoring, and I'll get into a little bit of that in the next talk. And then obviously we have to be able to adapt this, a system, a healthcare system, to a wide range of illnesses and injuries. So there's my contact info. I also have an ISU email, which you guys have available in the email chains that are sent out. So well, I think we're okay on time. I guess I have a minute or two for questions. This is a cool quote by Konstantin Tsiolkovsky, who was a self-trained Russian mathematician who at the turn of the century actually understood in his writings the effect of in space and in orbit we would not have a gravity like we do on Earth. So he has this great quote: "The Earth is the cradle of mankind, but one cannot live in the cradle forever. Hence our need to consider multiplanetary species going to say Mars." So with that, I will set up for my next talk. And does anybody have any other questions? Short questions?
I have one, if I can.
Okie doke.
Yes, so I was thinking, like related to the last part, you were talking about the use of genetic or omics information in general. So considering space tourism, because I know that you are like consultant in that topic, if you consider that like on astronauts it's difficult to make genetic tests because of course they are employees from governmental employees, so it would be more difficult. But for example, for tourists in space, it could be easier to make genetic tests and then see the effects like after mission.
Yeah, absolutely. You know, we've flown there's been 8 ISS tourist missions, and that there are other ones too, like there was a Korean astronaut, and in Mir there was a British astronaut. So you need long duration space flight to really study these effects. The problem with, say, doing a suborbital flight like SpaceX, like Blue Origin's New Shepard, or Virgin Galactic Spaceship 2, those are only 5-minute exposures in microgravity. So it's really, it's such a dynamic environment because you have the launch loads, you have 4 or 5 minutes of microgravity, then you have the reentry loads. It's a very dynamic thing. Should we test them? Yes, and you know, Blue Origin has got an extensive program to study science payloads. So we could possibly work out some of the bugs and how we would collect samples, et cetera, but we really need longer missions. And hopefully these long duration missions, or the missions that space flight participants, i.e. space tourists, fly on the space station is really our best bet. But I certainly see we could start testing some of the technology for on suborbital flights. Now, SpaceX has a lunar mission flyby, which will be several days, and that I think they're going to fly 6 or so tourists, artists mostly. That might be a good one to exploit. The problem is, you know, you got to have people that want to do this for philanthropic reasons, and all the ISS spaceflight participants did a lot of extensive outreach, and some of them did a lot of science. So I think this is a great opportunity. You're absolutely right. We should take advantage of every opportunity possible. I'm a big fan of this, and I follow it. And of course, you know, Professor Wotering is an expert in this area, and she probably has some great ideas as well as to how to implement this in the populations. The other thing is we're going to be able to fly people with far more substantial medical issues and really understand pathophysiology because we're going to fly. There's 600 folks signed up for Spaceship 2, and you know, we're going to get a lot of experience because of the larger N numbers. But yeah, you're absolutely right. We should definitely try to exploit that.
Thank you.
All right, so next thing, how to practice medicine in space.
Hang on one second, John. Marco, did you have a question?
I did, Virginia. I wasn't sure whether to prioritize the listed questions or take one here.
Let's see if we can get through these.
Well, I mean, I can answer your questions in more detail and give you, I've got tons of reference material. I've got all the space medicine books electronically and, so I have a huge amount of reference material. If you want, I can send you links. I have links of all these different talks that I've done and also that are available. And then also huge reference files on Dropbox.
Dr. Clark Marsh, thank you so much for your time and your talk. Really, really, really interesting. A lot to digest. I do have a short question regarding radioprotectants. Have there been any studies concerning the Fukushima and Chernobyl nuclear disasters as analogs for radiation studies?
Oh, it's a great analog. I think that they were using potassium iodine in the area. I'd have to check with my friends. I have colleagues of mine that follow this very closely. I'll have to check into that. But Fukushima is natural disasters are great test beds for how do you deal with, a sudden contingency. And the other thing is you've got large numbers. So that might be an area that I don't have any specific information on that, but it's certainly one that we should actively pursue. Maybe that would be your thesis topic. By the way, I supported Jessica Mears' master's ISU thesis on neurovestibular effects of spaceflight. Gosh, when was that? Early 2000 timeframe. So, and of course, she just got back to Earth. I haven't talked to her since then, but she's going to be a wealth of information as well. But yeah, I think the Fukushima one would be a great one to pursue. I'd be glad to help you out on that. I have a lot of space radiation files, but I would say, I'm not the right person because I'm not an expert in this area, but I'd be glad to get you a foothold for you.
Be happy to chat about it more and with Jessica.
Yeah, for sure. Okay, so ready for round two?
Yeah, the rest of you that had questions, put them in the discussion group, please. Press on, John.
Okay, here's round two. So Ginger wanted me to talk about how to practice medicine in space, and my caveat is I haven't practiced it in space except remotely as a crew surgeon. But I have a lot of friends who are astronaut physicians, and certainly they're a wealth of information. I have a huge file on space anesthesia, space surgery, but I'm really a big fan of trying to convert surgical diseases to medical diseases. So anyway, how to practice space medicine. Again, my disclaimer, here's a cool shot of the Earth and the moon in the background. That's that thumbprint size picture, or the size of the moon from Earth is about the size of your thumbprint, and if you're on the moon, if you look back at the Earth, it's about the size of a thumbprint. Interestingly, they're the right size, so we see eclipses, which is kind of cool. So space medicine it's a multidisciplinary specialty, and it's not just, perhaps medicine isn't the right term because it includes everything. It includes psychology, physiology, pharmacology, and a lot of interfaces with the other domains such as engineering. So we see bioengineering, we see industrial hygienists, we see all kinds of folks that, especially because a lot of the systems like life support systems have to keep the crew alive. And so
John, I'm gonna interrupt you. I'm sorry, but we're still seeing the last slide of your last talk.
Oh, that sucks. Oh, I'm sorry. Let me see here. I'm going to close this out. Okay, now how do I share?
Go down to the green screen share button at the bottom.
Oh yeah, sorry.
And you can then choose the
PowerPoint
window.
Okay, cool. Sorry about that. Thanks for interrupting. Share. Is it showing up?
Not yet, but I think it's getting there.
Yeah, I'm so glad I didn't put videos in because
the
videos would have just been awful with this bandwidth. So are you seeing it now?
No, I'm not.
Darn it.
Juliana said she isn't either. Okay. Ah, there we go.
Okay. Is it the full screen?
No, and it's gone now. It was the PDF, not a PowerPoint.
Oh, yeah.
There's the PowerPoint.
Okay.
And it's not full screen.
Yeah, I'm trying to, is it full screen?
Yep.
It looks like it's cutting off part of the bottom.
It does. What's up with that?
I don't know. Hopefully, here's my disclaimer, same as last time.
Okay.
I was talking about the picture of the moon.
Oh, that's gorgeous.
You know what I love about it is, so I do some work in the stratosphere, and for you all that are soccer players, the Earth's atmosphere is like 3 sheets of paper on a soccer ball. And if you think about it, you know, 100 kilometers would be 33 kilometers per sheet. So that's kind of how it is to get to space. And most of my work recently in the stratosphere was that first sheet of paper, you know, about 110,000, although we were in the second sheet. Anyway, here we go. Space medicine, it's a multidisciplinary specialty. It's basically health, wellness, fitness, and then medical. And I really want to stress the importance, as I think medicine should be focused on wellness and health, not on waiting till you have a disease and then dealing with it. It was coined in 1948, which shocks me because, you know, that was way before we were actually flying humans, but it was when we were starting to shoot animals up on suborbitally on V2 payloads, you know, captured V2s after World War II. And then also stratospheric balloons were heavily utilized to study radiation. They had a mouse that if it got hit with a galactic cosmic ray, it would turn a black hair white. So they would use mice as dosimeters, which I thought was really cool. And that was done in high altitude balloons. Anyway, I do a whole talk on balloons because I kind of think they're really cool. They're a great way to get to near space with you know, about 1/100th of the cost. So here's a picture of the Soyuz capsule. That's our lifeboat. That's how we get home now. Although very soon, the end of May, they will fly Crew Dragon. I'm convinced of that. I had a large part in the early stages of that program, and I'm very proud of that. Anyway, how do we do it? Medicine on Earth follows the same way we treat medicine in space. And healthcare delivery, and notice I don't use the word medicine, is about primary prevention or primary approach, and I'll talk about each of these in length, secondary approach, and tertiary approach. And unfortunately, medicine traditionally, my colleagues traditionally worry about diagnosis and treatment. And I'm also a master's in public health, and my feeling is we need to really put an emphasis on prevention. And it's far better to prevent a viral spread than to treat it with a ventilator. So prevention, 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 that's the base of the pyramid. We do that by crew selection and pre-mission optimization. And what a pre-mission optimization is, you're going to be undergoing some effect, and so getting acclimated ahead of time. If you guys, I'm a big fan of expeditions as training tools. I do a lot of stuff with the National Outdoor Leadership School, going on expeditions, because expeditions are a big area that you can learn about how do you package stuff. Stuff management. Mike Barrett told me this term. He said, our most important job is stuff management, is managing the stuff that we take and getting it out of small confined spaces and deploying it and using it and stowing it afterwards. Because we are constrained by space and we are constrained by time. And so how do you get at something? So the base of the pyramid for crew health is always about primary approach. The secondary approach is to counter the effects when you're in the environment of the degrading effects of the environment. And so a big area there is exercise. And then the tertiary approach is what we consider as our traditional healthcare terrestrial model, is also something we have to consider. But to me, that's the very top of the pyramid and should be the smaller part. Now, how do we, I put this list together, how do we ensure success on exploration missions? And I also look at this in expeditions on Earth, like when we went to Devon Island. Hopefully we'll be doing that in the next summer. Is that you need to find people that embrace this approach. Motivation, resilience, adaptability, creativity, resourcefulness, extroversion, empathy, emotional stability, and self-confidence are all attributes that I've found are really, really important. And if you don't have them, then you need to work on it. So this is something NASA now sends all their expedition crews to the National Outdoor Leadership School to teach them some of these skills. Get exposure to all the kinds of environments that you possibly could be experiencing in space. So I do ocean sailing for weeks at a time, where you have to basically manage stuff in small spaces. You're getting motion sick. You know, that's another great tool as well. A healthcare system is basically these four components: people, equipment, procedures, and training. And I'll talk a little bit about each of these with a heavy emphasis on equipment. But the reality is that you can see the human has to interface with all of those things. And the one difference about practicing space healthcare is that it's often done with a remote component. In other words, the subject matter expertise may not reside on board the vehicle. And hence, we use remote access with a crew surgeon or a biomedical engineer or somebody who's the subject matter expert for this particular system. And we are going to have to change that paradigm big time. So as a crew surgeon, I work in mission control, and I have 3 back rooms to support those efforts. There's a biomedical engineering, there's the life sciences activities, and there's the space radiation analysis group. So in the front room, I have 3 back rooms supporting me. The crew medical officer is an astronaut who is trained to provide medical care with this system. And they're not usually a physician, although we've had a lot of more physicians now in the astronaut corps. And I think there was one mission where we had 4 or 5 physicians on ISS, somewhere from the Space Shuttle, and some were ISS astronauts. Would we need an astronaut physician for an exploration class mission? Somebody at least at the advanced skill level, say a paramedic or somebody who's had expeditionary wilderness medicine training. By the way, that's a great opportunity, and you don't have to be an astronaut or a physician to do that. You can do wilderness medicine training through the Wilderness Medical Society or the World Extreme Medicine. There's a whole bunch of different places. Astronauts also undergo extensive training, both with their crew members and also with the mission control component, to practice these skills. But this is going to have to change, and I'll talk a little bit about that in a sec. Procedures. We're a very heavily procedurally oriented organization, and so we have books, and now they're available electronically with a manual procedure viewer, so you can get faster keyword searches. The one thing we train our crew members to use the medical checklist. Even if they don't have communications, they're going to have to do that. In flying, when we fly, we have what we're called bull-face procedures, or emergency action items. And crew medical officers are trained so that they at least memorize those particularly for basic, the basic life support, airway, bleeding, and circulation issues. And then the equipment, which is now called the Crew Healthcare System, or CHECS, is the equipment loadout, which is where we see the pharmaceuticals. Here's one of the missions. This was an ISS assembly mission. This was a Japanese, German, and American mission, which I thought was kind of ironic because, 50 years after this mission took place, 50 years before that, we were fighting a war to end all wars. And even though I've been in combat, I'm a real ardent supporter of maybe we should work on things like space exploration instead of wars. anyway, the team it's all about the mission and the team, and that's what the mission control represents. And by the way, this was Gerhard Thiele. He's a good friend of mine who lives in Cologne, and he was one of the crew on that mission. Or actually, he was the capsule communicator for it. So here is the front room. This was a heavy, intense phase during a spacewalk where we actually have 4 crew surgeons there to break the workload up. This is the biomedical engineering console, one of the 3 back rooms to support us, where we have the strip chart recorder, and then this is another shot of the mission control. Medical training, I'll tell you, it's never enough. So all of the crew, at least on the ISS now, are trained at least 9 or 10 hours in basic life support and how to work with the crew medical officer using the equipment, the medical checklist and protocols, especially for managing a contingency event. So 9 hours doesn't seem like a lot, but considering they have a lot of other vehicle systems, they also, you know, have to balance their training. And what you have to think about is, how do you keep proficient at this for a mission that's going to be 2 years long? The crew medical officers currently are basically EMT basic and maybe get to paramedic level. They go and ride ambulances. They get 40 hours of actual training, and then local emergency medical they ride in ambulances. And they cover these categories. These are the actual specific categories. Diagnostics, therapeutics is where they get the introduction to pharmaceuticals. Decompression, sickness, dental. The countermeasure system is the secondary system, primarily exercise equipment, and the main preventive system on orbit is the monitoring of the environment to ensure that the atmosphere and water and surface are not going to provide toxicants. And then the various emergency responses, such as advanced cardiac life support, and we'll talk about where we're going to go for expeditionary exploration class missions in a sec. These are copies of the medical checklist. Every mission, they compile lessons learned and update it, and if something's critical, they'll change it actually during a mission. The US first started getting into long duration missions in the Skylab program, where they flew 3 missions of essentially 1 month, 2 months, and 3 months. And their medical system was quite robust for their time, and this was the mid-70s. This is Joe Kerwin, who was the first astronaut in space, who was a Navy colleague of mine and a really wonderful guy. There he is there listening to one of his crew members he was in Skylab, the Skylab 2 mission. Here's the medical kit. It was about over 100 pounds of gear. And you'll notice that everything's in small confined spaces because stowage was an issue. But it included, for the first time, diagnostic capabilities, some minor surgery. I mean, it was a quite robust kit for the mid-70s. In the space shuttle, you know, these were the longest mission was just shy of 18 days on the extended duration orbiter mission. But this is a small volume space, and the shuttle kit was broken down into an emergency medical kit, which all had little red tags on it, and that was for emergency medical response. And then the essentially the medication and bandage kit was where the ambulatory healthcare system was. So these were would be about a medium-sized day pack each. And there were 2 of those that could store in a mid-deck locker. And crew would train on these, and they were used extensively. Maybe, Ginger, you'll talk about some of the medication use. Here's the point I want to make. These are the medical kits are all very tightly packed. I mean, it is unbelievable how hard it is to get something out. And so the emergency kits always had red tags so you could deploy those. But imagine trying to, this isn't like an ambulance where everything is stowed away in drawers or easily accessible, or in the emergency room or ICU where they're on roller carts and everything's easily accessible. They're all stowed. So getting access to this, look at how tightly all these drugs are put in here. I mean, they're really, really a challenge. Haldol, you know, that was used. that was something they started flying to avoid psychotic episodes after one of the payload specialists lost it. This is the early space station assembly. So the ISS currently, its system is probably, I mean, if you count the volume and mass of all this, it's quite extensive. It's several hundred pounds worth of gear. And I'll go over it in a little bit more detail. We do microbial sampling, atmospheric and water measures, and radiation. A lot of times these are sent back to Earth, the samples are sent back to Earth for analysis. The countermeasure system is the secondary system. It's primarily to provide interventions for the musculoskeletal and cardiovascular deconditioning. But crew also find that exercise is a very therapeutic for their behavioral health aspect. And then the health maintenance system is the tertiary system that is mostly diagnostic and therapeutic. And its primary purpose is to stabilize and get somebody fit for return to Earth in the Soyuz or in the upcoming Crew Dragon. Here's the environmental health system. This is all the different hardware. So you can see this is quite a bit of hardware. Obviously, ISS, remember, it's got almost 400 cubic meters of habitable volume on board for 6 crew members, which is a lot of volume. So we are not volume constrained on space station, which is somewhat unfortunate because we have a lot more capability than we would for a deep space mission. The countermeasure system is the secondary system, and it includes a number of exercise systems and also the crew health monitoring system. So, you know, they'll monitor electrocardiograms during certain exercise phases, and usually in a prelude to a spacewalk. And I'll go through this in a little bit more detail here. The 3 main countermeasure systems are the cycle ergometer on a vibration isolation system. That's for aerobic fitness. And another aerobic fitness system, and also was supposedly going to help with bone density, was the treadmill, where you had loading and unloading. Here you see Mike Full on the treadmill, and these have to isolate the vibrations to keep those pounding motions from interfering with the stability of the crew modules. You can actually see the crew exercising, even with these vibration isolation systems. You can see the crew exercise. So they dampen, but they don't totally diminish the perturbations that are transmitted to the vehicle itself. And here you see Ed Liu, who's one of the early expedition crew members, on the resistive exercise device. And this is the primary countermeasure for musculoskeletal deconditioning. The early one only gave 300 pounds of force. Now the new one, the advanced resistive exercise, gives 600 pounds of force. And we are now seeing major changes in crew bone density and muscular skeletal muscle deconditioning improvements with this system. Will we use this for a deep space mission? Wow, it'd be hard not to for a transit time of 6 months at a minimum, in some cases even longer, maybe a year. So the health maintenance system, as you can see on this list, is primarily involves advanced cardiac life support, and you could also use the advanced life support pack for a toxic inhalational exposure. I'll point out this to you. This is the crew isolation system, and the reason it's called the crew medical restraint system. That is a insulated board, so you can use the defibrillator, which is now just a small automatic external defibrillator, to prevent the shock electrical forces from going into the vehicle and causing damage. But look at the size of this system. It's a wall-mounted rack. That's just for the crew health care system that deploys this health maintenance system. We have several racks for the other systems as well. But crew will routinely practice this. They'll set it up and do a cardiac resuscitation drill during every mission. This is a full mid-deck locker equivalent for the, this is the ambulatory kit, the ambulatory medical pack. And you can see that this would be stuff for routine health monitoring and, say, for routine medical conditions such as motion sickness, sleep, back pain, headache, and whatnot. The advanced life support pack has got all the equipment stowed for airway access and ventilation, including a ventilator, and for emergency responses. So this is the another full mid-deck locker equivalent size for the advanced life support pack. Where are we going to have to go for exploration class is now a whole league up. And so what you see here is, you know, in addition to what we currently provide, which is ambulatory care and basic and advanced life support, we now have to add a level of trauma component and even the basic surgical capabilities. Plus, we currently use telemedicine on the ISS, but we're going to have to contend with the fact that the telemedicine is not going to be real time or near real time. It's going to be store and forward. And then there's much more likely possibility, because of these extended long durations, that we might have to deal with a palliative care issue, including how do you stow a body after it's deceased, after a person's died. So a lot more things are going into consideration for exploration class missions, which, remember, are missions over a year outside of low Earth orbit. So this is the exploration medical conditions list, and there are about 100 items on here that are now being actively addressed with the integrated medical model, which I think you have been assigned to look at some of the. So the integrated medical model was something set up probably over 15 years ago, and it basically takes a condition or a symptom, and then it talks them through how much will you need, what kind of equipment will you need, how long can you support somebody. I'll talk about where we are now. So right now we have the prevention and countermeasures, which are the primary and secondary parts of the healthcare system. And we have ambulatory care, and we have some we have some ability to manage significant illness and injury, but we are not even at the level of a standard ambulance that we would see in, say, Europe or the US. We can manage them and stabilize them for maybe a couple of days, but the primary response currently on the ISS is to stabilize and transport. And we have to break that mindset, because now in deep space, we don't have an immediate return capability, and we don't have real-time communications. So really, mission control, the mission control center concept has to fundamentally change to mission support center, and I'll get into that a little bit later in the talk here. So here's where we're going to have to go with levels of care. And level care, this is in one of the NASA documents, and basically their expanded level of cares. So right now, for the space station, we were at level of care 1 and 2. I mean, for the shuttle, we were at level of care 1 and 2. But for ISS, we are now going to this higher level of care. And you can see that each of these is incrementally added. So if you're at level of care 3, this would also include level of care 1 and 2. So we are now in the level of care 3.A, which is ISS missions over 30 days. That 30 days is the definition for long duration missions. And we have limited life support, and we have some minor wound care capability, and we have some telemetry, but we have dental care, but we do not have surgical care other than, say, just a superficial laceration. We do not have. So we're now in the process of going to, how do we support level of care 4, which is a lunar outpost. So it's only 3 days away if we need to abort. We need to have enhanced capabilities, but ultimately we need to be moving towards a deep space exploration class, which would be over a year outside of low Earth orbit. And that now includes more on the autonomous care and some basic surgical care. So where we are now is in the early phase of 3A. We need to start thinking about lunar sorties are going to be, say, week-long stays on the lunar surface, build our experience base, and then longer missions on the lunar surface. And then the lunar surface is base camp for a Mars mission. And like I said, a Mars mission, just the transit times alone, at the very best of cases, it's 60 days with a month-long stay, and an optimal flight for a mission of 500 days on the surface is going to be, you know, a total of you know, probably close to 1,000 days. So that's where we are, and this is just a basic drill that's been looked at as where we are now for shuttle, for station, how much equipment. These are in kilograms, and mass volume sizes. We have to start thinking about how do we go for a Mars habitat where we want to have what we have on space station, and these are things that still have to be determined and worked out. So some of the drivers for space, for all hardware systems, but for the medical systems, these are a list of all the drivers I came up with. Now, NASA will say it's mass power, volume, robustness, and cost. But these are all the things that we really have to consider for human space medical systems. Mass power, volume are still in the play. We need things that are robust or durable. This is one that we have not spent a lot of time on, but now it needs to be exploited, which is autonomous systems. So a system is going to give you not just the manual procedure viewer of the medical checklist, but it's going to take what you input into it and potentially give you a list of differential diagnostic conditions and then some therapeutic treatment plans. Making things interactive with the human is really important, and that's an area that, you know, obviously along the way we're going to have human factors engineers. How do you get by with training, minimal training, or what we call just-in-time training? So you come up with an item that comes up and then it says, okay, this is something, and basically it talks you through how to do a diagnostic procedure or a therapeutic procedure. Now, this is one that's going to have to be looked at in recyclables. Now we're doing studies now on ISS with 3D printing, including 3D printing of medical instruments. And one thing I've talked to with the 3D printing folks is, hey, you know, one of the things we want to have is sterility. So if you, in the process of recyclability in a 3D printer, can you ensure its sterility? So that's another area that's exploitable. If you have a system that breaks down, rather than throw away the whole system, can you put a module in and replace it? This is currently what's done in the space station. If something breaks on the alpha magnetic spectrometer, they have stowed modules that are likely to need replenishment. But again, you're going to have to carry everything with you or pre-deploy it and ensure that it's still viable after years on say the deep space radiation environment. We are constantly plagued by stuff management. And if any of you have ever done an expedition where you've carried all your gear, including the things that, you know, your own medical kit or whatever, how do you get it out when you really need it? Boy, that's a big issue. And there are probably some areas that could be worked on there, just common sense deployment of stuff. All systems in space have to have an assessment of its toxicity and off-gassing. And some plastics off-gas huge amounts of toxicants, especially volatile organics, and they have to be tested for their flammability. Those packs that I showed you used a material that was developed in the Apollo program called beta cloth, and it is a low off-gassing and low flammability for electronic devices, they all have magnetic signatures which can interfere with each other, and you have to test all your devices for its ability to not interfere with other electronics. So that is a basic rundown of the drivers for technologies, particularly healthcare systems. So I'm going to show you where we've gone with respect to some hardware development. And this was Advanced Diagnostic Ultrasound for Microgravity, called ADAM, was developed after the Columbia mishap. And it was the ability to use the existing ultrasound machine with real-time guidance with terrestrial support. And it basically, with 3 or 4 hours of training, an astronaut was able to fully use the ultrasound machine and do diagnostic quality ultrasounds. And this was because they couldn't send up new stuff because the shuttle was grounded for a couple of years. And so the crew was trained on how to use the ultrasound and how to do diagnostic imaging in an attempt to basically use the system that was on board and basically transmit information, i.e. electrons, to update the crew. And it was a very successful program. It was so successful that it's been exploited now for advances in care in third world countries where, say, a local nurse is trained for a couple of hours to do diagnostic quality ultrasounds for all organ systems. And now it's also being used extensively by athletic teams where the trainer has this ultrasound, a small ultrasound capability, and can do diagnostic ultrasounds primarily of musculoskeletal injuries. So this is what's called just-in-time ultrasound, where you basically will plan to do a study, get talked through, and this is all in a book and in a CD, and I can make this available for you if you're interested, just to show you how things have advanced. So it talks you through looking at this part of the ultrasound machine. This is how you're going to place the probes. This is the 3 different angles that you're going to use the probe, and how to use it to examine virtually every organ system. It's pretty freaking amazing. This is Peggy Whitson, and that's her bladder showing a jet from the urethra, or the ureter from the kidney to the bladder, showing that her ureter is patent, and this would be something that could be used to evaluate, say, a kidney stone. Peggy was a renal physiologist, or is a renal physiologist. She's retired now. Here's a cool shot that shows you can actually examine the pupil even if the eye was swollen shut. And this was an expedition crew member. Actually, this was Expedition 10 with Salazar Sharapov doing the study on Leroy Chow. And there's a picture of those two. There were only 2 crew members on ISS during the period that the shuttle wasn't flying, and they were able to do diagnostic quality ultrasounds after a couple of hours of training. And these are some of the reference documents. Now, this is really a great shot of the evolution of ultrasounds, which is now the current imaging modality in space station. This was the ATL 1000 on the far left. Look at how big that sucker is. I mean, it's just monstrous big. Okay, this would be equivalent to, in my era, when we had a cardiac ultrasound that was on a big cart, and it had to have a specifically trained ultrasonographer to operate it. The current system uses the GE VividQ, which is a laptop-size ultrasound machine, and there are multiple ultrasounds. There's Sonosite machines available, and now we have palm-top ultrasound machines that are being used, like the Butterfly system, and this is a small GE ultrasound machines that are PDA size. So, and this is in the over 20 years how much ultrasounds have changed in their ability to do diagnostic imaging. Again, it's mass and power and volume that are going to be seriously reduced as a result of this advance in technology. There's also the ability of ultrasound machines to do hemostasis, that is, to cauterize blood vessels. That's pretty cool. So these are some of the areas that we're looking at currently, again, to exploit the precision capabilities of omics research, using the quantified self wearable monitoring systems. I use a Sunto system, but there are there's Apple Watch, there's tons of different systems out there that are available. And the advances in imaging or monitoring systems with non-invasive systems is absolutely amazing right now. And it's advancing very rapidly. Again, you want to be able to make a wide array of systems available to intervene with both diagnostic and therapeutics for a variety of injuries and illnesses. One of the things that is going to be heavily exploited in the future for autonomous delivery is, guess what? Artificial intelligence or machine learning algorithms that are developed so that it can take advantage of all the Earth-based experiences. But one thing you always have to remember is these things can fail. And I use this talk in my human factors talk as well, but this is a movie that was well before most of your all's time, that came out in, when was it, the 70s? It was 2001, A Space Odyssey. And in that system, the HAL 9000 computer revolted against the crew and basically took over the vehicle. And this is a quote, from the HAL system: "I'm sorry, Dave, I'm afraid I can't do that." So we always have to be mindful of the fact that as we implement new technologies, there are things that can fail. One of the things I won't have a lot of time to talk about, but is deep space radiation causes bit flips. And those bit flips cause they're called single event upsets in computer systems. And it's interesting that bit flips occur in the same place that we see retinal flashes from deep space radiation. And we see those occasionally even in the protective Van Allen belts, because there's a hole in the Van Allen belt called the South Atlantic anomaly, and also at the polar regions, the magnetic pole, the Van Allen belts dip down, so there's less protection at the high latitudes of the North and South Pole. So these things affect computer systems, particularly high-density electronic circuits, and they also are detected in the human by retinal flashes in the eye. So basic kind of overview summary is we need to have a continual advancement in healthcare systems to attain the highest level of care balanced with the mission constraints. The top goal is going to be to preserve the crew health and performance as a team. And then the secondary goal is individual health. And then, obviously long-term effects of radiation, et cetera, we can manage when we get back to Earth. The advances in precision medicine is to focus, instead of a population-based approach, which we traditionally in medicine have been doing, to now an individualized, personalized approach. We're going to have to adapt our systems to operate initially as semi-autonomous systems, and then eventually as autonomous systems. And that is going to take a sea change from what we're used to now with ISS, where we have virtually always have some comm available with very short periods of dropout, and also high bandwidth. So we're going to have both bandwidth and actual comm connectivity delays with deep space missions. Here's my contact info, and I kind of rushed through this so we can have some time for questions, but I have a lot of material if you're interested for future. And this is a great quote I love from Robert Goddard. "It's difficult to say what is impossible, for the dream of yesterday is the hope of today and the reality of tomorrow." Thank you so much.
Thank you, John. This has been wonderful. I think there are a number of student questions ready here. Let's back up a little bit.
Can you see my ISU mug?
Yeah, that's great. Yvonne, did we do yours?
I should write all these down because you know, your questions help me formulate new ways or areas that we need to focus on.
We've got them captured. We can send them to you. Yvonne's not answering?
Yeah, hi, sorry, I had to switch off my video because my laptop was disintegrating. Hi, Dr. Clark, thank you so much. It's been absolutely fascinating, and we all feel the same way. We've been expressing our awe and joy about the lectures with you. My question comes from, although it's about the heart, it actually comes from a neurological perspective. So my question is to do with mitral valve prolapse, and whether or not things like that are tested for human spaceflight participants before going up into space, because they possibly could have a factor to do with future headaches or migraines that may not be caused by intracranial hypertension, as well as possibly to do with brain fog. But it's not something that's captured unless you have an electrocardiogram. So
yeah, we do. Now we do cardiac echo. So after when we transition from short duration missions on the shuttle to the long duration missions on the space station, which has been occupied since the late 2000. So we're 20 years now into this. They started to do a very enhanced amount of screening, and basically they probe every orifice with a scope. They scan and image every part of the body in an attempt to fully understand and follow these issues for long duration missions. So do we screen for mitral valve prolapse in astronauts? Yes, we were doing that in the shuttle program. And I'm familiar with the relationship of migraine and mitral valve prolapse. So we do screen for that. And I think in general, that would be a disqualifying for long duration flight. Now, that's, you know, government programs, all the space agencies, which include the European Space Agency, CSA Canada, Japanese, and the Russian Space Agency in the US. So all 5 space agencies, I believe, have disqualified that, but I can check on that. The standards, the medical standards for NASA have previously been considered not for public consumption. But as I understand it this year, and they just finished an astronaut applications cycle, but I heard through the rumor that they're going to make the astronaut standards public. So that will be able to be officially released. But mitral valve prolapse is considered a disqualifying condition. I'm pretty sure that there will be commercial spaceflight participants that fly on the Virgin Galactic Spaceship 2 that will have that, though.
Yeah.
The question is it an embolic source? That's been always the thing about both migraine and cardiac cerebral emboli.
Okay, Erica?
Hi there, thanks for your lectures today. They were really great. I wanted to talk a little bit more about sustainability and self-sufficiency in space. I know that you had mentioned it a few times that you think, you know, it's needed for long duration space flights. And there are a few different ideas that have been proposed, such as the 3D printing and utilizing plants to make drugs in space. So moving forward, do you think that 3D printing is going to play a big role in this? And like, I know that the BFF in the ISS is already looking at like cells and tissue. So do you think that the next movement beyond materials and technology would be 3D printing of drugs in space?
Well,
or
I think,
are there any alternatives that you think show more promise?
first of all, space shouldn't be the last test bed, and so we need to be doing stuff like that on Earth. Now, I'm looking down and say I want to write down all these questions, topic areas, so I can have
Seriously, John, we've got them captured, and I'll send it to you.
Okay. Yeah,
Yep.
because I have, for each of those, like microvalve prolapse and 3D printing, I have specific reference material I can link you with. But yes, so before we start doing it in space, we need to have it worked out on the ground. Are there going to be, doing it in space is a lot, it may be harder and may be better in some ways, because you know, in your 3D printing, you don't have to worry about gravity. So that could be an advantage or a disadvantage, depending on, you know, the issue. But I think 3D printing is such an, you know, it's expanding evolutionarily. The SpaceX they build much of their vehicle with 3D printing. 3D printing is a huge area, but most of it has been in physical materials science, and we need to be doing more in the realm of biological materials. But 3D printing pharmaceuticals, I think until we get big input from, big pharma, that's going to be slow because it's so technology intensive. But do I see that as a fruitful area? Absolutely.
Okay, great. Thank you.
Shahaz?
Yes, hello, Dr. Clark. I really enjoyed your lecture. My question is related to the behavioral issues that you mentioned during the last lecture that some astronauts have faced on previous missions. To what extent are crew surgeons or crew medical officers that are on board specific missions trained in human psychology, if at all, to be able to recognize and treat psychological or mental disorders or issues?
Oh, that's a great question. So unless they've had formal training, and actually, you know, psychology's always had a bad rap in space. The Mercury astronauts always poked fun at the psychiatric or psychological testing, and resisted it because the psychologists didn't necessarily have the same perspective. But that has been much improved because there's a huge behavioral health team with psychologists and psychiatrists who are actively involved in ISS now. And for example, they have behavioral health private conferences with the astronauts. So just a mental health care provider and an astronaut has conferences now, you know, probably in the order of every other week or so, or more often if necessary. For example, if they had some issue with the family, you know, going on, or something that's happened. So the fact is that our society has got a much better awareness in the importance of behavioral health. And so it is now much more prevalent in astronauts to be more touchy-feely. The old days was, you know, I call it the Iron Warrior concept, is just suck it up and deal with it. You know, that was kind of the male mentality, especially for military test pilots, you know. But we are much better adapted at doing this now because there's an appreciation from a societal level of the importance. And that's become very evident now as we all are faced with our own isolated, confined environments with, you know, COVID restrictions. So, but astronauts themselves, there are a few that might have a background in it, but I don't know that they receive, other than a cursory training in it, even as crew medical officers. You know what they have? They have restraints. You know, early on in the shuttle era, it was duct tape. You know, the guy the payload specialist that kind of, his payload failed and he became despondent, and the crew were worried he could pull a handle and jettison the hatch in space and they all would have died. So there's been a better appreciation. That's why they fly Haldol now. But I think, again, don't focus on treating them with a duct tape or Haldol, focus on preventing it. So right now there are programs available that can take optical character recognition, even from low fidelity video images, and look at that and say, hey, you know, that guy's depressed. So there are ways that we can non-intrusively monitor it, and some of these are being heavily exploited. I can go into some of the details on that, you know, at a future time. But we have a lot better appreciation that it's a real important concern. The other thing is, and I'll be quite honest about it, I think the multicultural diversity, flying women, they're much more attuned to emotions than guys are. So the fact that we now have a multicultural, multi-gender crew is wonderful, because it allows the appreciation for things that wouldn't necessarily be, done if it was just an all-male test pilot crew. So yes, it's a super big deal. Uh-oh, I can't hear you, Ginger.
Yeah, that's because I forgot to unmute myself. Altane, you want to ask your question?
Yeah, thank you. Thank you very much, Dr. Clark, for amazing presentation. And I just had a quick question on the integrated medical model, since it provides two outputs, alpha number and mass of medical consumables. And one of the parameters affecting the alpha is a gender mix. And do you expect that women will have less chance to be selected to deep space missions like Mars because of the greater number of model fatalities when it comes to female crew compared to male crews when it comes to, in regards to the space radiation risk?
Well, that's a super great question. I mean, our longest duration flyer is Peggy Whitson. I think she's got 667 days in space. That's it. She could have gone to Mars, been there a month, and come back. So I know personally that she faced that issue, and NASA said part of the reason was the radiation risk people. Every time they did a study, they would just be, oh my God, this is terrible, this is bad, and so there was all these restrictions. Literally, women were allowed half as much radiation as a male of comparable age. And so part of it is we've done a better job at understanding that radiation risk, and we follow it very closely. I think it's primarily going to be a concern for young women, in the kind of early reproductive years. And I think for a deep space mission, you probably don't want to send somebody who's got young children at home, whether they're male or female, because you're going to be gone, and your risk of not returning is going to be certainly within a couple of percentage points. I think, and I can say this having been in the military, where women were first introduced into combat and then now flying frontline fighter aircraft. I mean, it has brought a humanity to the situation. And if I had to pick a gender to send to space, I would send an all-women crew before I'd send an all-male crew. Why? Well, one is they're lighter, so they burn less fuel, they take less consumables, they're better at social interactions, and the other thing is that they bring to the table an ability to speak their mind. And so we will always send women to space. Now that means women can die in space, and they have, we've lost women in space, and that's just part of the game. But I don't ever see a time where we're going to restrict women from flying in deep space. We might want to take older people because they're less vulnerable to radiation, and they're past their reproductive years, and they're, where your focus is, are my kids doing? And I can tell you that because of Peggy's direct appeal to say, why am I being biased because I'm a woman, led to a reassessment of the radiation standards, and she now became the leading record holder. Whereas before, under pre-existing standards that were, I think, excessively conservative, they wouldn't let her fly. So, my hat's off to her and the others that follow. Christina Koch just did, what was her mission? Just shy of a year, That's
right, she was 11 months.
Yeah.
Yeah.
And we're going to see more of those. I think NASA's planned for 5 or 6 more one-year missions, and hopefully more.
Mm-hmm. Mm-hmm. Okay, Christine.
Okay, hi. Thanks, Dr. Clark. I had a couple, well, two quick questions, but I'm happy to take one, and one was more of an observation. But at what point do you think, do we start seriously considering some kind of genetic modification as a potential radiation mitigation strategy?
Well,
I mean, there are ethical choices, obviously, in that, but.
Here's my read on it. We need to be multifaceted in how we approach this. And how could we potentially do that? Now, an area I follow human health and performance in a lot of different arenas. And one of the kind of hot topics in this area is doing genetic modification if there was a specific defect that you could repair genetically. They're now doing that for developmental single gene effects right now. So hopefully there will be advances in the terrestrial application of gene modification or making up for an enzyme deficiency or whatever. But in general, what are some options that are out there? And one of them that I follow, which is in the chemotherapy and cancer radiation, therapeutics arena, is changing our metabolic capacity to be better capable of reducing risk. And there's several ways it could be done for this. One is going to an alternate fuel source for the brain, which is ketone bodies. And they're now using that intermittent fasting for chemotherapy and radiation effects, to reducing those. Why is that? Well, the body goes into a different mode if it's on, say, a ketogenic diet or a intermittent fasting. And so it reduces cellular activity in normal cells, and abnormal cells continue to divide. And so they're the ones that are going to be more preferentially affected by chemo and radiation. And so that has a huge amount of promise. Both you can do it with a diet, you can do it with intermittent fasting, or you can do it with ketogenic supplements. So there are some areas that's being actively pursued in terrestrial healthcare. The other one, which I follow and I'm also absolutely fascinated about, is hibernation, or really what I would call metabolic torpor. And so there are a lot of animal studies where metabolic torpor is used as a survival tool through wintering over months in mammals. And I just found out, actually, I was in a meeting maybe a month ago with a guy who's a lifelong friend, Pascal Lee, who's in the Mars Institute. And I was saying, we were at a meeting specifically targeting how does NASA deal with future exploration needs and how we would support that. And he said, there are humans that undergo metabolic torpor like bears. And I go, are you sure about that? And he goes, yeah, because we spend a lot of time, or he in particular spends a lot of time in the high Canadian Arctic. It's called Inuit torpor. So we already have on the Earth a human, species that are doing this. What are the advantages of it? The advantages are huge. The advantages are that you reduce your metabolic demands. You don't burn up as much oxygen. You produce less carbon dioxide. You need less, nutritional supplementation, and all those are things that would significantly improve the logistics support required for an exploration class mission. But more importantly is, by reducing our metabolic activity, we're going to be distinctly less vulnerable to radiation-induced effects. So I said, we got to look into this. And the problem is that it's hard to study Inuits because they're protected in Canada. But I'm fascinated by the idea that we could look at Inuit torpor, which is currently practiced, and see how we could eventually reduce our radiation risk, but also reduce our logistics burden.
That's awesome. Wow, that's
cool.
cool.
I have a lot of information on that. If you want to do a project on that, I'd be glad to help you out.
Yeah, definitely.
Simon? Or Marilla, whoever gets to their mic first.
I'm glad I'm on unmute because I don't think I could find the button to do it.
Hi, this is Mirella. My question is actually because on the bio that they sent us about you, they said that you're the medical consultant for companies such as Virgin Galactica and Galactic and SpaceX. So my question is, how are they viewing this next phase on human space exploration for interplanetary missions, such as going to the moon or going to Mars? And if they think about it, or if they are looking into developing medical equipment and to be used for this kind of missions, and if you could tell us a little bit about it, of what the future awaits for us. Thank you.
Yeah, that's a great question, because I think, you know, how do we get to the moon? We had there's three legs of the stool, maybe more. There's industry, academia, and government. Okay, and the reality is that we can't do any of these things that we plan on doing without all three. So the ability for all three of them to play together well is a crucial part of it. A big advantage now in going to exploration on Mars is driven primarily by SpaceX and Blue Origin. So Virgin Galactic, what are they interested in? They do suborbital missions, but ultimately, you know, assuming you know, we get over this pandemic and people want to start flying again, is they want to do suborbital point to point. So Virgin Galactic is not going to be, at least in my estimation, a key player in deep space, because their focus, when they take their system and then they put it commercially, is to go to suborbital point to point. You can go from the Americas to Australia in 50 minutes. So that's what they're interested in. So Blue Origin and SpaceX are the key people involved in the exploration class missions. And both of them have active programs. Blue Origin is, first of all, they're very secretive. I've been up there. It's an unbelievably cool place. Jeff Bezos has rebuilt the model that Jules Verne had written about in his book From the Earth to the Moon. And it's actually a conference room that goes up and down. And so he's totally committed, but they keep their cards real close to their hand. They do not show what they're doing. I have contacts there, and one of them is Erica Wagner, and she's kind of like their science business development person. So she's always interested in new ideas to test out. But right now, they're going to be doing suborbital, you know, takeoff and landings to develop propulsive landing. But they're very interested in the long-term science aspects. And Ginger, I think you've talked up there, right?
Yeah, and Erica has made ISU an offer. We can get experiments in flight for $8,000.
Oh yeah, it's dirt cheap, and she is a key player. First of all, she's an avid space geek, and she's a smart, wonderful person. SpaceX, who I've worked with and still do, boy, they're another one that their focus is vehicle systems. And they look at the concept of, you know, people as not, in my estimation, they not as actively as, say, Blue Origin is doing. So their focus is on vehicle systems, and then the people will have to work it out. So it's different corporate, you know, cultures that are driving this. Now, but SpaceX has a full-time flight surgeon, Anil Menon, who's a great guy. I used to work with him on a number of different projects, but his focus is on supporting commercial crew programs. And it's obvious that a Elon Musk wants to go to Mars. He wants to die on Mars. And he said, hopefully not during the landing. But he wants to go to Mars. So he's going to do this. But right now his focus is on vehicle systems and less so on the human. You look at that Mars transit vehicle that they have, I think they're planning on 100 to 200 people on that for even a short 6-month mission. That's a lot of people, having to work together. So they're not as focused on the human side of a Mars exploration. They're focused on vehicle systems. Whereas Blue Origin, even though they're still just doing the propulsive landing part, they are interested in new ideas. So the bottom line is, we'll play with. I feel like we ought to have everybody playing together and sharing information. But those are the two main companies that are involved with deep space exploration. And the one that is kind of maybe not as far along, for example, SpaceX has Big Falcon rocket as a heavy lift vehicle, and Blue Origin is only got the New Glenn vehicle that they're in process of building. But the bottom line is both of those will be eventually interested. One happens to be more interested in the human side than the vehicle side, or at least they're equally correlated. So, and the other thing is Blue Origin has 3 astronauts working for them too. So they obviously are going to represent the human part of it much, much better. But these are great questions. I don't know if that answered it, but bottom line is they're both interested in it.
Simon? Okay, we're still missing Simon. Guillaume?
Well, hello. For me, it was not really a question. It was just a comment. For the scientific article talking about the alpha term, the difference between men and women is only of 1%. And I have checked other scientific articles, and they say that other risks have to be assessed to really check if it's a benefit to only send men crews.
Yeah, that's cool. John, I'll send you these references.
I would love to see that, because I follow gender. I have a whole section on gender issues that I can make available as well. Because I'm very passionate about it, and partly because I realize, man, there's no way we're going to do this by ourselves. Now, it's interesting. Who has the exact opposite philosophy? The Russians. The Russians are, they had a bad, they had a chamber isolation experiment with 2 Russians and a French-Canadian scientist. And the, I don't know how to be politically correct, but the Russians, got frisky. And it was very hard for the woman on board to not, have issues with that. And part of the reason is the Russian culture is very kind of, even though they revere women, they're also very chauvinistic. And it was very interesting because they were like, well, I'm a male and you're a female, and, we have bodily needs and you're here, and what's the deal? And she took offense with it, rightly so. And they said, well, we're not going to have women on any of our crews. So that was, part of the issue. But I think that the U.S. side, I don't know if that, I'm pretty sure it's a formal policy, is they will send mixed gender crews. There is absolutely no way we can go on without the beautiful involvement of both of the male and female species of the species. So I would love to hear that, because my feeling is, we've always explored together, and we always, will in the future.
Okay, I'll send those along to you.
And do we have to prove it? If you need it proof, so be it. We'll do it. We'll do that too. when I was on my Knowles trip, we would have a 4-man tent, and there was no constraint to women or men in there. You just had to learn how to be respectful of privacy. And part of that was, I mean, you're not sitting there stripping down buck naked, but the fact is that you have to be respectful of people's issues. And they wouldn't say, well, we're going to only let men and women together. In fact, it was interesting. The one woman in my group was married to somebody who was in another tent, and can you imagine, I think I felt more sorry for him because he's sitting there going, there's 3 guys in there with my wife. Anyway, the bottom line is we got to learn to deal with that.
Okay, I have a few church bells going on in my background, but I don't think it's too bad. Simon wrote his question. He's interested in whether astronauts take performing enhancing drugs like nootropics. And I know that I have seen in medical records at least one astronaut note to that for us to see and research. John, do you know anything about this?
What drug? What were they on?
It was paracetam.
Oh yeah. I'm familiar with that. So who's hot on nootropics is the Russians, and they actually have them in their med kit. The only nootropic I think we fly is modafinil or Nuvigil or Provigil. I think it's probably Nuvigil now.
It's Nuvigil now.
Yes. So, but we don't call it a performance enhancement drug. It's for alertness, and I think nootropics are a fascinating area that should be exploited to the maximum degree possible. Now, there's so many different nutraceuticals out there that are supposedly, beneficial. Ginkgo biloba. I mean, that would be a great research topic, by the way, and maybe that would be something I could work with you on as well, because this is a very important area. What I think is you just have to weigh all the factors. So one is, pharmaceutical grade quality, so that you know what you're getting. Be very open-minded about the benefits and adverse event profile. Understand that the astronauts are going to be in a different environment, and so are some of those environmental factors going to play into in that situation. For example, the microgravity fluid shifts, the changes in organ blood flow, all those kinds of things. But we ought to come up with some lessons learned for that and pursue it. Now, since we already have Nuvigil in the inventory, that would be a good place to start. I'm a big fan of, because I've followed this work in the performance arena for the military, is ketogenic supplements and or other ketogenic modalities. Because why? Because ketone is one of the only brain fuels that we have. We have glucose and ketone bodies, and there are different ketone supplements, that look at beta hydroxybutyrate and acetoacetate. So there are even differences amongst those. They're used extensively in pediatric epilepsy now. Another one I'm very interested in, because I have colleagues of mine, Ginger, it's Don Carnegas, but is cannabinoids. And I think there's a lot of room out there to look at a lot of psychoactive substances, but the best thing is to start with a good scientific plan. But this is a great topic, super awesome.
Well, John, I can't thank you enough. You've been very generous with your time and your experience. We really appreciate it.
Well, I was honored to be a part of this, because for me, this is my, one of my major torch passing events. For you all, the future is so bright, and I just cannot express the honor I have to be a part of your future legacies. Thank you.
Thanks so much, John, and have a good day.
You too. Great chatting. See y'all.
Yeah, good catching up with you.
Yeah, and send some questions, and I'd be glad to share with you the resource files I have on things and ideas. And you guys, from the sounds of it, it's awesome amount of projects that you all will be working with. So Thanks again.
Okay, bye-bye.
Yeah.